Assalamu alaikum. Today we'll talk about non-invasive ventilatory support. We have to understand the indication and contraindication of non-invasive ventilatory support and to identify the difference between the types of ventilatory support and how to use the non-invasive ventilatory support in different settings. The non-invasive ventilatory support is a mean to support the feeling respiratory function by giving oxygen-enriched gas under pressure without requiring endotracheal intubation. Best used as a short-term strategy to buy time for medical therapy to treat rapidly reversible cause of respiratory failure. What are the benefits of non-invasive over invasive ventilation? We all know that the benefits are to avoid airway trauma for the vocal cord, allow the patients to for intermittent eating, drinking, talking, avoid needs of sedation, and avoid the risk of ventilator-associated pneumonia. The indication of non-invasive ventilatory support includes the acute hypoxemic respiratory failure, especially in cardiogenic pulmonary edema, acute hypercapnic respiratory failure in COPD patients, and prevention of post-extubation failure in high-risk group. Post-extubation failure occur in around from 12 to 14% in patients, with a mortality ranging between 25 to 50%, and it might reach more than 50% in high-risk patients. The high-risk group include a patient more than 65 years old, patient have chronic cardiac or respiratory decompensation, patient with rapid shallow breathing index more than 105, the patient who have medical critical illness myopathy, prolonged mechanical ventilation for more than 7 days, patient with ineffective cough, patient with poor blood gas control during the journey of invasive mechanical ventilation, and patient with positive cumulative fluid balance within 3 to 5 days before trial of extubation. The prevention of also the non-invasive ventilatory support can be used in patients with post-operative high risk of respiratory failure, which occur within 48 hours of surgery. Patient need re-intubation within 48 hours after surgery, or prolonged intubation for more than 48 hours after surgeries. The definition of prolonged ventilation after surgery. The high-risk group for post-operative pulmonary complication or post-operative risk of respiratory failure include high age group, male patients, patient with American Society of Anesthesiology, SS3 or more, patient have a greater number of comorbidities, a patient with a positive fluid balance within the previous 3 to 5 days, patient we didn't go for lung protective strategy in the OR. Patient who continue smoking for 8 weeks before surgery. Patient with obstructive sleep apnea, patient with hemoglobin less than 10 grams per deciliter, and patient with prolonged anesthesia for 8 hours, and also the site of surgery, if it's thoracic surgery or abdominal surgery in morbidly obese patients. Treatment of post-operative extubation failure, we do not recommend to use non-invasive ventilation as a routine maneuver to treat post-operative extubation failure, except in COPD patient. So the contraindication of non-invasive ventilatory support include the post-cardiac arrest patients, which patient with hemodynamic instability, the patient have an inability to protect airway either if there is bulbar or pseudopulbar palsy, or patient with disturbed conscious level with gas coma score less than 12, patient who has excessive secretion and he needs of excessive or tracheal or nasotracheal suction, patient with active GIT bleeding, a patient with esophageal or gastric surgery, patient with facial trauma, all are contraindication for non-invasive ventilation. And we have a predictor of success for these patients also. A younger patient less than 65 years old, patient with lower Apache or SEPS 2 score, a patient able to cooperate, better gas coma score more than 12, less air leak and the intact dentation or no PERD, moderate hypercarbia, PCO2 less than 90, and moderate acidemia, better gas exchange, better heart rate, respiratory rate within the first 1 to 2 hours of using the non-invasive mechanical ventilation. What are the types of non-invasive ventilatory support? We have different types, including the high-flow nasal cannula, the non-invasive ventilatory with face mask or nasal mask, non-invasive ventilation with a helmet. So the high-flow nasal cannula, we use it in order to use the effect of PEEP, which ranges from 5 to 8 centimeter water. We use a high flow for from 40 to 60 liter per minute using the active humidifier. It will wash the dead space and it will reduce the inspiratory effort of the patient. Using the non-invasive ventilation, it provides pressure support to unload the inspiratory effort. Both helmet and face mask provide pressure support, and both will give a beep to allow all over alveolar recruitment. But better tolerability is common in helmet more than non-invasive face mask or nasal mask. The indication of non-invasive ventilatory support includes the acute hypoxemic respiratory failure. We use mainly the high-flow nasal cannula or non-invasive ventilation using helmet. While in hypercarpic patients, we recommend the use of non-invasive ventilation also in post-operative patient at high risk of post-operative respiratory failure, in non-surgical at high risk of extubation failure. We recommend non-invasive over high-flow nasal cannula. The setting of non-invasive ventilatory support, while starting the setting of high-flow nasal cannula, we should assess the patient tolerability of high flow. So we start with not with 40 liter per minute, start with 20 to 30 liter per minute with humidified oxygen. We use only the active humidifier, never to use the heat moisture exchanger or HME filter for patient using high flow nasal cannula. Then we adjust the FiO2 to reach the target SpO2 according to the patient condition. While in non-invasive ventilation using the face mask or nasal cannula, we use a non-invasive ventilation also with helmet pressure support. We can use higher pressure support in helmet. In non-invasive face mask, we use the pressure support of 7 to 10. We reach up to 12 in a non-invasive ventilation with helmet. Also, we use higher PEEP in helmet up to 12 centimeter water. FiO2 adjusted according to the target SpO2. We can use in post non-invasive ventilation with face mask, non-invasive ventilation with helmet. We can use the CPAP mode using only PEEP, positive ended expiratory pressure. We can assess the pressure and the flow curve for these patients. We see that in patients with non-invasive ventilation, we can use if we use a pressure support, we can augment the inspiratory effort of the patients. How to monitor the non-invasive respiratory support. To monitor the non-invasive respiratory support, in high-flow nasal cannula, we use what is called the ROX index, which is a ratio of oxygen saturation. We divide the SpO2 measured by the pulse oximeter to the FiO2 over the respiratory rate. And the accepted ROX index better to be 12.7 with sensitivity up to 85% and specificity over 4100%. And we follow our patients in the 2 hour. If patient at 2 hours, the rescue index, the ROX index is less than 2.8, or 6 hours is less than 3.4, or 12 hour it's less than 3.8. So we have to consider intubation. The most important issue for this patient is respiratory rate. Why we use a respiratory rate in this equation? Because the most injurious part, as we said before, the high inspiratory effort of the patient and the high respiratory rate of the patient, which will lead to self-induced lung injury. So if your patient is tachypneic and has a low ROX index, we have to go for invasive ventilation. In non-invasive ventilation monitoring, the predictor of failure include the lower SpO2, FiO2 less than 120 or worsening trends, also PF ratio less than 200 or worsening trends. Patient have air hunger, exhale tidal volume after 1 hour more than 9.5 ml per kg, and the Hacker score 5 after 1 hour of non-invasive ventilation. What's Hacker score? Hacker score, it includes a score of heart rates, including heart rates, pH, gas coma score, PF ratio, and respiratory rates. It ranges from 0 to 25. And any patients with Hacker score more than 5 are not candidate to continue a non-invasive ventilation. How to wean our patient from high flow nasal cannula? As any weaning procedure, we have to decrease. What's more injurious is the oxygen, not the positive PEEP or the flow. So we have to decrease FiO2. We decrease FiO2 to gradually to reach saturation target saturation from 90 to 97, and we decrease the flow by 5 liter per minute every 2 hours, and we monitor the respiratory and the breathing patterns, the most important issues during monitoring our patient their respiratory flow and 30% oxygen. We catching FiO2 of 9 or 90 to 97. We can go to start Venturi at 10 liter per minute. We have in a two illustrative case. First one is a 50 years old male patient with history of ischemic heart disease presented to the ER with dyspnea. In an initial assessment at the ER, his blood pressure was 70 over 40 millimeter mercury. SpO2 was 82% on room air, respiratory rate 35, and norepinephrine started 0.4 mic per kg per minute. They measured the ABG showed that the PO2 is 50, PCO2 is 65, and saturation is 85%. Best treatment for this patient is, what do you think? Best treatment is inhalation. The illustrative case is a 65 years old female patient with history of diabetes, hypertension, presented to the ER with dyspnea and hypoxemia. The initial assessment at the ER, blood pressure is on CO2 is 85% on room air, respiratory rate was 50 breaths per minute. A patient was diagnosed to have a COVID pneumonia. CPAP mask was tried, but the patient's respiratory rate did not decrease, and the patient intubated and ventilated. 5 days later, the patient condition improved, and the decision was taken to wean the patient. 4 hours after weaning, the patient became dyspneic, tachypneic, and the APG showed hypoxemia. The best treatment for this patient is what? Service treatment. We cannot use the non-invasive ventilation for this patient is a previous failure. We have to go for re-intubation and ventilation. So to sum up, there's the most important issue in this lecture today is to know what are the contraindication of non-invasive ventilation, unable to tolerate apnea, need to for airway protection, the copious secretions, acute respiratory failure, and once the patient is not tolerated for non-invasive ventilation, we have to go for invasive ventilation. And the best way to So, to be sure that the patient will benefit from non-invasive ventilation is to choose the best mode and choose the best size of the non-invasive face mask. Thank you. And if there is a question, okay.